Okay, we prepare to start. Hello everyone, good day. I'm Mark from Taiwan. I'm a pathologist with special interest in cytology and immuno-oncology and viral diseases. In this difficult time, I'm thrilled and honored to have the opportunity to humbly share our limited experience on Taiwan's national policies and strategies on public health and biosafety. Today our topic will be COVID-19 in Taiwan from a pathological laboratory's perspective. And before I begin my talk, recently I published an article of commentary review in Cancer Cytopathology. It's open access and free download. I hope everyone, if you have interest, you can download it. And if you want to write emails or correspondence to my articles, I'm very happy to reply. Please enjoy it. The outline of this talk will be briefly introduce the COVID-19 and Taiwan's general strategies and our public health. And then we will discuss the testing methods and our testing strategy. And lastly, the most important is our biosafety of pathology labs. COVID-19 is a disease caused by SARS-CoV type 2. SARS-CoV type 2 belongs to a family of envelope-positive strain RNA viruses. If you see the phylogenetic tree, the SARS-CoV-1 is here, the SARS-CoV-2 is here. They are similar, but their phylogenetic tree is not directly connected to each other. The type 2 seems more similar by genomic analysis, more similar with the other bat SARS-like viruses. So it's very interesting, but physiologic responses of these two types are very similar. The other coronavirus, such as MERS and the human coronavirus at Hong Kong University 1 and OC43 and another 63 and 229E, these viruses create very mild symptoms to human. MERS is far away from the genetic tree or apart from SARS-CoV. And the SARS-CoV-2's basic structures, you can see in the outer surface, it has a spike protein, S protein. It's very important because spike protein can attach to our angiotensin converting enzyme receptor. It's a big inducer to introduce neutralizing antibodies. And then we can see the membrane protein. And membrane protein is the most abundant protein in intracellular formation as viral particles. And in between the membrane protein, we can see the hemagglutinin esterase. It's very critical for the coronavirus invasion and migration. And in the core, for sure, is nuclear protein and genomic RNA. The SARS-CoV type 2 have only one single strand positive sense RNA. Compared to these two types, SARS-CoV-1 and SARS-CoV-2, they are both belongs to beta coronavirus family. And along with the MERS coronavirus, they all belong to beta coronavirus. Compared to these two types, they have many similarities. They use the same receptor on human cells. The receptor is angiotensin converting enzyme 2, and this receptor have variable abundance in our somatic cells. That's why we can see in different cells have a different viral load and can detect different viral existence. And as I say, the spike protein will be primed by the cellular protease. We called it the TMPRSS2. So if you use a TMPRSS2 inhibitor, it's a serine protease inhibitor, can block the entry of the viruses. And then the coronavirus can induce the neutralizing antibodies. But in this scenario, the neutralizing antibodies have much effectiveness in type 1. But in type 2, currently, their neutralizing antibody effect seems moderate. Not so dramatic, but still have somehow effective therapeutic effect. So there is their difference by the observation and the studies. This is the cartoon figure. You can figure out what I say. The type 1 and type 2, they use the same angiotensin converting enzyme receptor to go into the cell. And the priming depends on the TMPRSS2 priming. And if you use the TMPRSS2 inhibitor, you can block their entry. And compared to the type 1 and MERS, the type 2 coronavirus so far have an incubation time much longer than these two. And in some studies, the incubation period may be several weeks. But in average, we are believed 2 weeks is a general average. About the symptom, the fever still be a major symptom, but asymptomatic patients are much larger than MERS and SARS. MERS and SARS creates more dominant symptomatic patients, but SARS type 2 seems more asymptomatic. And about the GI symptom, diarrhea, the GI symptom much less than MERS and SARS. And in the biggest case cohort published from China, they have up to 1,000 patients from over 500 hospitals. You can see the death rate is around 1.4%. And the critical, the severe patients are up to 5%. And still, we got a lot of healthcare workers, our colleagues, are involved in this outbreak. The symptomatic reports are majorly fever and cough, but still we have a lot of people, up to 80%, they have no typical X-ray or CT changes. That's why I say this type 2 seems more presented more mild or asymptomatic than MERS and SARS coronavirus type 1 in 2003. And in laboratory examinations, lymphocytopenia is the dominant finding. This is the major transmission routes published in my article. So far, we still have too many unknown about these viruses. And everyone would believe the major transmission would be droplets, air droplets spreading, and direct contact with infectious persons, and indirect touch with contaminated surface or items. Then you can get the virus and you get incubated. And the other two transmission routes, so-called airborne or fecal-oral transmission, they are both possible because there are some articles published these transmission possibilities. But they are believed to not be a major transmission routes because they still need to prove themselves. But by the evidence, if this virus is airborne transmission, the transmission reproducibility would be much more. And if I'm infected, I will spray more than my family. Even strangers will be infected by my airborne spreading. But so far, you can see in the early spreading, still depends on family clusters or reunion clusters, people with associate contact history, and cluster gathering would be infected. So I think the droplets, direct contacts, indirect contacts are the major transmission. And I want to talk about the face mask issues. The face mask issues between Eastern countries and Western countries, we have very different viewpoints. We would have this kind of joke. You see, in the Western countries, we wear ring mask to cover our lower half of face, such as ninja or such as assassins. But in Western country, our big heroes, our people in justice, they're wearing face masks to cover their upper half of face. So it's different. It's different. So we always say we wearing mask because in Eastern side because we want to keep ourselves protected. But in Western countries, I think wearing mask to cover their mouth is not by nature accepted. And this issue would not go funny without scientific evidence. So we need more scientific evidence. Recently, the Hong Kong University published their studies about the respiratory viruses shedding in exotic breathing and their efficiency of transmission by face mask. And you can see without surgical mask, the transmission of coronaviruses, influenza virus or rhinoviruses are about around 30% of infection rate. But with surgical mask, the infection rate is much lower. And this is droplets particles. And about airborne aerosol particles with surgical face mask are still have effective protection, although compared to the big droplets particles are less effective but still effect. So the surgical mask could protect you from the transmission and prevent you infected. As this, the coronavirus, influenza virus, and rhinovirus are very prevalent infectious agents in our seasonal or opportunistic infections. And because some audience want me to talk about pathological findings and cytopathology findings, but in this talk I won't focus too much on these introductions. So I just talk a few articles published. This is the earliest article just published their pathological findings and in Lancet Respiratory Medicine. This article is just a case report, but its cited rate is over 300 citations. So it's very important because their findings have been proven again and again. They use autopsy cases, and they found in this case they found the lungs, the patient's lung, have dominant ARDS-like changes, just like the hyaline membrane formation diffusely with exudates in pulmonary alveolar spaces, and type 2 pneumocytes hyperplasia. And this way you still see the hyaline membranes and the inflammatory cells. And more, you can see some syncytial multinucleated cells who had bearing the cytopathic-like changes. And the other reports would say cytopathic changes, they found the viral particles in the cytoplasm through the electron microscope. It's another story. And you can even prove the infections of viral RNA through CISH staining. And anyway, you can prove the lung infected by the SARS coronavirus type 2. But about the liver and the heart, they can only see the sinusoid dilatation and a few patch lobular inflammation. And also in the heart, they can only see a few patch infiltration of the mononuclear inflammatory cells. That, in the summary, in the other system from this case report, the respiratory system still be the big finding system to illustrate this COVID-19 disease, and the other organs seems not so dramatic. The finding seems less, or the finding seems associated with the post-mortem changes or clinical therapeutic effects. And again, in another modern pathology article, they published the 4 cases of autopsy biopsies from 4 cases. This is case 1's lung, this is case 2's lung, this is case 3's lung. You can see these 3 have one characteristic finding is hyaline membrane formation. This hyaline membrane is more delicate, and this is focal hyaline membrane formation, and the other is type 2 pneumocyte hyperplasia. And the widening and or the inflammatory infiltration in the lung interstitium. The inflammatory in case 2 is mild, but in case 1 it's very dominant, even have a few exudates, pleural exudates in the lung. And in case 4, the case 4 is more dominant to show a late stage. The case 4 have very dominant neutrophilic infiltration in the lung, and even show the fibrinoid vascular necrosis and the type 2 pneumocyte hyperplasia and intrapulmonary hemorrhage. And these 4 cases have different liver changes. In the case 1, only periportal inflammatory changes and very mild lobular inflammation. In case 2, he is a cirrhotic patient, so the liver shows a cirrhotic change. And case 3, the lobular inflammation is more dominant, but still patchy and patchy. And case 4 have variable changes from sinusoid dilatation and patchy portal inflammation and focal necro-inflammatory focus. So in liver, the changes is not directly associated with the COVID-19 virus infection. It's more associated with their underlying disease and their post-mortem changes or therapeutic changes. And about the heart and the other system, they didn't say they find the dominant viral infection associated changes. So, in summary, in pathology published cases, we have very limited reports from autopsy reports, and the autopsy cases they show most associated to this viral disease is from the respiratory system and mostly is infected in the type 2 pneumocytes or even macrophages. If you want to check the viral infection evidence, you can do the electron microscope or the immunostains or the CISH, and you can find out the viral particles. But in H&E, you can only see focal cytopathic changes in some cases. Okay, we will go on next section. And this is all my parents worldwide. I miss you because in this outbreak, all of us cannot easy to go abroad, and all the conference have been cancelled or postponed to next year. Hope everybody stay safe, and the people, all my audience, stay healthy and sound. We will have a better future. We hope the outbreak ends soon. Okay, before talking about Taiwan, we can look back from the case increasing line. In case of increasing line in early America, you can see in North America and South America in the early week of COVID outbreak, most countries double their cases within every 3 cases. As for United States, Brazil, or the others, Costa Rica, or Mexican, or Dominican. Anyway, in the first phase, their case increasing line is very dramatic. And now the outbreak have gone for 2 months, the second month. You can see United States start to flatten its line, and Brazil, Canada is start to flatten. But in Mexican or Domingo and Costa Rica, they have different phase. Costa Rica or Bolivia are still upgrading. So this is the second month's outbreak. Every country in America are still in fighting to control their increasing. I think control to flatten their number. And we look back to Europe. Europe is the second wave, just after Asia. It's the second wave. The outbreak starts, and in the first months, including Italy, Germany, France, and other European countries, they have the same increasing number within 5 days or 3 days. So it tells us in the very early beginning we should stop the virus. Otherwise, every country, poor or rich, you will go a very sharp case increasing. And then Europe now is going to the second or the third month of outbreak. After the 2 months of COVID-19 outbreak in Europe, most countries has been flatten their case increasing curve, but they just flatten. We hope no more increasing or no more second wave of dramatic increasing can be well controlled, and then we can say this outbreak would be safer. Iceland, I think, did the early control very well. A few reports will say the Iceland do the good control because it's an island country, and it did a very good national screening. I appreciate this method is very wise. This method to border control and to do the public screening can pick up the suspected case very early, and then you can flatten your case increasing much earlier than the other countries. And you can see why the other countries start to flatten, because they start to launch the social distancing to control every infectious case, to increase more infection. And lastly, we go back to Asia. The Asia, we can see most of the Asia has been experienced at least 2 or 3 months of outbreak, and every country have different outcome. We can divide it in 2 groups. One group is their doubling case within 10 days. The other group is their doubling case over 10 days. And you can see Japan, Singapore now is in the first group. They control their case increasing very well in the early phase. But now they go into another impact of case increasing. Probably maybe immigration employees in Singapore, they have outbreak in dormitories. And Japan have a lot of imported cases, but they didn't do very strict border control, and turned out to be a big outbreak in local communities. So the Japan and Singapore now is increasing much more than before. But in Thailand and in Taiwan and Vietnam and Cambodia, we do the border control very well and strictly behave our people to follow the national policies of keep social distancing and keep yourself a good hand washing and wearing mask, so on. So we can control our cases still in very strict. Why I draw this line compared to our data world? Because our data world have only I think about only 1 month of our data, because we are not joined in WHO. But our first case is in January, much earlier than the other country. So in fact, Taiwan has been experiencing 3 months of outbreak, but we control the outbreak very well. Now we go back to focus on Taiwan. Taiwan is a small country in just beside mainland China, and our size is very small compared to New York State. We are only 1/3 sized than New York State, but we have very big population. We have up to 23 million citizens. And our GDP ranks the 22nd place of the world. Why we say Taiwan would be very lucky in this outbreak? Because we have a lot of citizens living in China and working in China, and we have very close economical connections, and the people traveling between mainland China and Taiwan is very frequent. And especially this outbreak starts before the Chinese New Year. A lot of people work in China would go back to Taiwan before Chinese New Year. It means they may bring back the virus in January. So we supposedly should be a very big outbreak in our society, but we are very lucky to have to respond and react this outbreak threat very strict and very early. Is our cases so far. We have only 395 confirmed cases, and only 6 people dead. And recovered case is 155. It means still have 200 confirmed cases are isolated and quarantined in hospital. And it's very long course. Although they are confirmed, but they are not easy to recover without no more viral RNA tested. Because in Taiwan, our recovery criteria is 3 negative. They should check their oral swab, nasal swab, negative 3 times in different time. And only 3 negative you can say you recovered. But compared to WHO, 2 negative is adequate. But in Taiwan, 3 negative just for sure to go to recover. And we recruited up to 50 or 48,000 cases suspected. And you can see our time schedule. In our very early phase, this first wave is in Chinese New Year, just after Wuhan city lockdown. A lot of people go back to Taiwan, and we have the first wave of confirmed cases. And then another case increasing wave is in March, because at that time, the Europe and America start to have their big outbreak. And a lot of people come back to Taiwan or travel to Taiwan and to be an imported case. So far in Taiwan, imported case constitutes most of our cases. Our local case is few, only 14% of confirmed cases. And why we can do such well? I would say it's it's a big co-work of major decisions. The decision made very early, and our president full authorization to the command center. The command center is assembled by our Minister of Health Care and the specialists of public health and the infection doctors. They organize a very good command center. And the Minister of Healthcare fully authorized by the President and take care every day's daily briefings and made every clear decisions and transparent information providing every day. So everyone can fully informed all the information. And they also negotiate the lawmakers to make special laws in this difficult time. And this command center build up the public trust. But public trust will be very important, especially in this difficult time. If you didn't have public trust, they are panic. They would have a panic buying. They would try to stock every resources. They will try to take advantages in different aspects. So build up public trust is very important. And we still have a very good backup is our healthcare system. Our healthcare system is very similar with the UK NHS system. It's a single payer system and nearly 100% coverage. And every citizen and even foreign residents can enjoy our healthcare with very cheap, affordable prices. We will talk the first decision making from our president. Firstly, our president is just newly elected, but she is a very wise lawyer and re-elected in this January. After his successful re-election, he activated the command center much earlier on January 20. And then the Wuhan and the other 3 cities are put on lockdown. And so and the command center noticed the face mask and the health workers are our major resources. So they start to set up a new face mask machine in January. And they start to restrict the Chinese citizens enter in Taiwan. So in the first wave, we didn't have so many cases confirmed because we have restricted their entry. And our face mask is a very big step to convert the population. As I say, in Asia, if you wearing face mask, is a safe method to convert you spiritually and mentally. Even it may have so much dramatic protection physiologically, but it's a big comfort if you have face mask, an adequate face mask to protect your family and yourself, especially when you are a health worker, is very essential. So to ensure the resources of face masks and PPEs is our first step. And now every citizen can use their health insurance card to buy 9 masks per 2 weeks, with every face mask only $0.2 US. And you can check the capacities by the mobile app or the national website to show a real-time capacity. Now, you can see this Taiwan is not the big producer of face mask, but how can we increase our face mask producing? It's because over 100 engineers from different, from 52 companies, they voluntarily to go together and assemble the face mask production units in 1 month to create 60 units. Then our production increased up to 50 million per day. Now we are only second to China's production. At least we can cover our citizens' need. So thank you for these engineers. And we can check our real-time capacities. My house is near the national hospital, and if I want to buy a face mask, I can check the pharmacy store nearby my house, and the pharmacy store in gray means they are sold out, and pharmacy store in green means their capacity is over 50%, and you can press and dot this pharmacy store, and you check the details. The adults' capacity is up to 500. For children is up to 2,000, and their selling time. This is very convenient for every individual to buy face mask in pharmacy store and check the real time selling capacities and time. And on the commuter, I traveled from Tainan to Jiayi, and I need to take the railway. I need to go into railway station, take a train for work. In railway station, it's a public space, a public place. In Taiwan, every public place should have a body temperature check. So you can see in railway station we have an infrared thermal imager. He's just like a robot here. And when you go into the railway station, this robot will check, and this is its monitor. If you are in fever, you will be shown in red. But in this case, in this individual, their race size is only in the head and in the show. So he's clean. If I'm totally in red color, it means I'm fevered. And this coworker will, at least this assistant will check my body temperature immediately. If I'm really over 37.5 of body temperature, I'm not allowed to go into railway station. And in railway station, you can see we keep the social distancing. Every chair will be in a gap to each other. And you can see even in the tram, every people are get apart from each other because we keep social distancing. And when I arrived at my hospital, our hospital has reduced the entrance gates to only 5 gates. And every gate will have a body temperature check again. And another method is I need to show my insurance card and insert to the smart card reader to read my traveling history and medical history. To check up, I didn't have traveling history or special medical history. So this smart card is very critical for buying face mask and check your traveling history and medical histories. And after check my body temperature, if I'm not fevered, I can go in and he will give me a stamp on my wrist to prove I'm clean today. And more than that, when I go into my office and open my computer, and the first screen when I start my system is this. I should self-report my temperature today and report my symptoms every day. This is an assurance for employer to get every employee's situation daily, and to protect the other employees infected by a symptomatic employee. So self-reporting is important, especially in hospital. Here I check. My report time is 8:43, and my temperature is up to 36. And if I have symptom, here will list my symptom. And the second, the command center build up the public trust. I think is the most important thing, because a daily briefing and build up a public trust is very important, especially for the public. The transparency is most crucial in this method. Transparency, the updating information and launch the very clear decision makings and high efficient to do everything is very, I think is a challenge to the team and to the government and to organized system. If they have been very efficient worked, they will do it very well. And I want to especially talk about the vigorous airport fever screening and the street border control. Because the street border control, we stop every foreign visitors in March, but much early than the foreign visitors. We stop our health workers go overseas, go abroad, since 2 weeks earlier. I think almost 1 month earlier than the travel ban of the foreign visitors. It's because our command center, the specialists think the health worker is our biggest resource, not second to face masks or PPEs. Because we have very good health workers in Taiwan, so that our health system can efficiently and effectively work on. So if our health worker infected by this virus and go nosocomial infections, our health system will be collapse. So they start their travel ban to all health workers much early in February. And now, just like the other country, all inbound travelers will be subject to a 2-week home quarantine. And more than that, we give them compensation fee for this home quarantine. And they just need to assure themselves stay at home and don't go outside. If they broke the rule, we will cancel their compensation fee and even have a penalty fee. And now is a social media era, so we need to spread our information more interesting and more cartoon or more accessible, more flexible. So our nation or our command center would use social media and TV and influencer broadcasting. So in YouTube, our pastors of social media, our Twitter of the nationals and the influencers will show up all the information and in clear and easy ways. Lastly, I want to talk about the core tip of our country is our system of health system. Our health system have been start from 1992, so it has been 25 years. It's an insurance premium based and 100% coverage to all citizens and foreign residents. And every Taiwan citizen just need to pay $25 to 85 per month. Then they can enjoy very cheap and very accessible health system. And the Bureau of National Health System insurance will pay to the hospital and physicians. And every citizen just need to pay very less. I think every OPD visit just need to pay $3 to $10 in each time. So it's very affordable. And mostly the hospital clinics or Chinese medicine clinics and Chinese medicine hospital are covered by this system. Compared to the other country of OECD and Japan and South Korea, Taiwan's cost in this health system is only 6.3% of our GDP. So it is very low cost. And in the past 20 years, this cost is not increasing a lot. It's just in a flat line. So our cost is keep low, but our effective work is still going on. So compared to the other developed countries, our GDP on health insurance, health care is much lower, but we still effectively do our job. Okay, again, we miss the Sydney ICC. Next time will be in America, and I think in 2012, 2022, I think in Baltimore. So everyone, please join the IAC and attend ICC. It's very good to meet friends and enjoy the course, and for sure enjoy our clubbings with all funny cytology guys. Cytology family is very good family. Everyone is very nice. And the second topic, we talk about the testing. You know, the testing is very essential because if the testing launched much early, you can control your infection much early. So detection, confirmation, response, if you can reduce the detection time and you can launch the detection reporting much earlier, you can prevent the potential cases of infection. If you see the total testing coverage worldwide, the Iceland, Estonia have the leading coverage, and Taiwan have only 2 per 1,000 people. Iceland honestly do a very good job of public screening, and especially it's a small island and easy to do the border control, and their population is not so large. They can do the national screening very well, but in North Europe, their coverage is very good. So I think if your country is in the early phase of outbreak, this coverage is very good to detect every suspected case and prevent their further spreading. But why Taiwan have only two people of coverage is because 2 reasons. One reason is our resource is not so much, but we still do a lot of testing. And the other major question is our confirmed case is very low. We have even tens in February, and now only 300 cases, confirmed cases so far, and mostly imported. So their contact history is very few. So our testing coverage is not so high, but we still do up to 40,000 cases testing. The other further data to show the coverage not the only issue is the testing per confirmed case. Taiwan and Vietnam do this part very well because every confirmed case means is a source of infection. So if you can check every confirmed case, always there potentially contact people, and you can test them and prove they are infected or not. It's more meaningful than just do the public screening. So every confirmed case we will do at least 122 people will be tested. It means all his contacts or her contacts people or indirect contact people we will check and make sure they are clean or no symptom. So it's very good strategy to make sure your testing is effective. And especially for a big outbreak or compared to United States or UK now, they cannot do per confirmed case so large because they are in big outbreak. And even the US is the leading testing in the world. They have the biggest tests so far, but their test per confirmed case is very low because now they are in a big outbreak. So if they cannot easy to check every confirmed case contacts. And if they do so, it's only meaningful for early phase. Now they are in an outbreak, the middle and late phase. So the strategy not good for them. They should pick up more confirmed case now. So another issue after testing is your after confirmation work and your resources. We didn't just pick up people. We need to do more than confirm. After confirmation, you need the hospitalized and isolated room. So in Taiwan, we have the negative pressure isolated room up to 1,100 beds. And compared to the Japan, they have only 1,870 rooms for isolation. So I think their room is in a big shortage. But so far our isolation room is okay. So our confirmed case are isolated in hospital, and we will check their viral detection before they recover. And because the confirmed work is now depends on the RT-PCR, so your testing abilities per day is very crucial to assure your testing can work on. And point of care tests are still necessary, because if you want to count on the RT-PCR, it takes a lot of resources. So a easier way to screening is truly demand. And Taiwan have cooperated with Denmark to start the rapid test. We hope that they soon to be approved by EU in this May. And lastly, we will go our major work of this topic, the laboratories biosafety. Firstly, we will talk about the surgical pathology. The surgical pathology, in conclusion, just follow the routines, because the surgical pathology, most of the surgical pathology samples are fixed in formalin. And formalin is the 37% of formaldehyde solution. 10% formalin for our routine use is 3.7% of formaldehyde solution. So this concentration of formaldehyde is much effective to inactivate the virus, the coronavirus and SARS. So every formalin fixed sample can be taken as inactivated sample. So they are safe. You don't worry about you are get infected by these form FFPE samples. Why I say so? Because in articles, formaldehyde over 1% have been proven can kill SARS coronavirus in 2 minutes. And the log 1 means 90% of viral reduction. 2 log means 99% of viral reduction and more. You can say more than 3 log. It means the viruses are almost gone, and it's a very safe solution to disinfect. So formaldehyde over 1% in our daily routine, 10% of formalin is 3.7% of formaldehyde. Is much more adequate than less. So every FFP be safe to deal with it. And the other issue is alcohol. The alcohol should be over 70% to kill the coronaviruses and the other viruses in this coronavirus family. You can see over 70% can effectively kill the coronaviruses in 1 minute. Only 30 seconds can kill. And the reduction of viral infected are over 4 log or 5 log. Is nearly no virus can live in this solution. But if the concentration go down, if only 70%, it will take more time to kill the viruses. So I would say the alcohol concentration is very crucial to disinfect the viruses. We should make sure our alcohol concentration high. The major exposure to surgical pathologists is deal with the frozen samples. When you deal with the frozen sample, just make sure you wear PPEs and in a special area so that you can do the clean work before and after you do the frozen sections. But luckily, most of the frozen sections are tissue fragments. They don't create the aerosol droplets spontaneously. Especially we don't do the vortex or the other aerosol generating procedures in frozen section or cutting. So you just need to alert this issue and keep yourself wearing appropriate PPEs. The PPEs for frozen section recommended by the UK Royal College of Pathology Society is wearing water-resistant gloves, water-resistant apron, and eye protection and the surgical mask. So N95 or FFP2 may not essential for frozen sections. As I say, frozen section didn't create aerosol droplets. You just keep yourself protected. It's enough. And then we go into our major topic, cytopathology biosafety. Compared to the surgical pathology, cytopathologists dealing with more fresh samples, direct smears, and we should interpret these samples by the risk assessment. The highest risk is the respiratory samples, from sputum to bronchoscope lavage. They are all belong to respiratory samples and at highest risk. Blood or bloody sample are the second, and eye discharge or eye droplets would have high viral load, so it also should be alert in and should be categorized in high risk, but they are seldom to test in cytology lab. Anyway, these three are proven in high frequency of virus nuclear RNA in RT-PCR. And so we should take a high level of protection. In the second group is urine and pleural and pericardial. Urine and pleural and pericardial, by evidence, they are not detected for viral RNA so frequently. Especially urine only have 1 or 2 articles published in PubMed to show in urine sample they detect the viral RNA in RT-PCR. But pleural samples and pericardial samples so far didn't have these kind of articles, but I believe maybe after a while there will upcoming articles talk about this issue. But theoretically, pericardial and pleural effusions, they are all in the thorax. So a degenerate or necrotic lung tissue, pneumocytes, or distal airway tissues would floating in these effusions. So to detect viral RNA is not, I think, is not a difficult or rarely things, but honestly, they are seldom be detected. These results. So by evidence, these three samples are seldom or rarely detected with viral RNA. So honestly, they should be clean, but theoretically, we think we should still take care and carefully deal with these three gray zone intermediate risk samples. And viral cultures, for sure. Viral culture means you have a living virus. In urine, in pleura, and pericardium, they are not easy to have a living virus to be cultured. And for ascites, cervical pap smear, and vaginal discharge, or semen, or synovial fluid, CSF, and formalin fixed cell blocks, they are taken as inactivated or very rare to be infected by to have the virus infection. So they are low risk to deal with. In my article, I would recommend by the guidance summary worldwide from US CDC and WHO and ECDC, Europe's ECDC guidance. These kind of samples are all with low risk assessments. We just need to do the good microbiological protection procedure as our routinely followed. So low risk samples, be safe, don't care, and don't panic. Just do your routines. For sure, do the clean works. Intermediate risk with viruses, we need to pay attention to them. But if your laboratory is running short of resources and you don't have adequate biosafety class 2 cabinets, you just need to pay attention to these samples and do these samples in a dedicated area and do the clean work before and after you process these samples. And high risk samples with virus, for sure, you need to do the process in a cabinet or with class 2 biosafety label with appropriate personal protection. And just like the frozen section in surgical pathology, roles in cytology is another issue because when you perform rapid on-site evaluation, you need to do the direct smears, and you need to expose to the same room in with the patient. So the performers as a specialist is at highest risk to do the roles. So when you do, especially when you do the EBUS, you should make sure this procedure is in an adequately ventilated room with airflow at least 160 liters per second per patient, or you do it in a negative pressure room. And you should wear a particular respirator such as N95 or FFP2 respirator, and eye protection, gloves, and long sleeve gown or apron, and limit the number of persons in this room. And for sure, perform your hand hygiene and ensure all the material be disposed after the work. So when you perform the roles, especially EBUS, take care of yourself and don't do the unnecessary roles for the routine patients. except they are proven clean, uninfected. Okay, lastly, I want to end up with a few questions because when my article published, a few people write an email to me, and I'm so appreciate their questions. Their questions made my articles more meaningful, and I learned a lot from them. And now I want to share you a few questions. Question 1, they asked me about the N95 mask for the personnel who perform the FNA is essential or not. Yes, the N95 or FFP2 in EU masks are very essential, but especially for the EBUS and oral FNA. The EBUS, the bronchoscope bioaspirates, and the oral FNA, the performers or the interpreters are directly exposed to the patient's aerosol droplets, and the bronchoscope even induce the coughing. So they are at highest risk. So they for sure should be in N95 face mask. But if you do performing thyroid or lymph node or soft tissue FNA, this procedure won't trigger aerosol or tiny droplets when you're performing the soft tissue fine needle aspiration. So you just need to make sure you're wearing at least a surgical mask. You and your patient wearing the surgical masks. And I think if you don't have adequate N95 or FFP2, wearing surgical mask is adequate when you're performing thyroid, lymph node, or soft tissue FNA. Should we arrange, the question 2, should we arrange all FNA in a dedicated site, such as in emergency medicine, OPD? Yes, for sure. Because in my article, in the second paragraph of performing precautions for the cytology professionals performing roles, I talk about this experience. In the past experience of SARS in 2003, they have been proved the use of dedicated to the room and associated equipment that only dedicated for FNA can decrease the risk for transmission from the patients. Because a dedicated place and a dedicated equipment, we will always remember they are infectious. So before and after we're dealing with the FNA of the patients, we will remember to disinfect them, clean them, and we will remember ourselves. When we go into the room or approach the equipment, we will do our self-hygiene very well. So it will be successful. Protect yourself and your co-workers. The question 3 is, we disinfect the N95 in a lab woven with 79 degrees Celsius for 40 minutes, and the same patient used the N95 for 2 days. Yes, it's not ideal to reuse your face mask. If you have adequate face mask, just dispose it. But if you are running a big shortage of medical resources, yes, reuse would be very ideal method, alternative method in this great shortage. Here are three methods recommended by Peter Tsai. Peter Tsai is a Taiwanese and the inventor of N95, is working and teaching in America. And he recommends 3 cleaning methods. One is rotation, to change to rotate your N95 face by alternative or outer and inner use, and steaming, and the third is baking. And the baking, I think most people would use the baking more because it's more easy and didn't take a lot of time. The researchers used at the Michigan State University have been proven to baking disinfection with their lab oven at 70 Celsius for 30 minutes can be effective disinfect the viruses. So I think the baking method is okay. You just need to make sure your oven is not a food oven, it's a lab oven. And the fourth question is very critical. Are all the commercial solutions for liquid-based cytology effective for disinfection? So far, if you look the SimPrep or SurePath, they are methanol-based or alcohol-based or formalin-based. You can see their different strategy of formula of solution. Because most the solutions, their fixative effect is very weak, but their hemolytic effect is high because the osmotic pressure is much higher. So they can easily to lysis the RBC. But the fixation, because their formalin or their alcohol concentration is low, maybe only 25% in published papers talk about this. So we cannot assure they can be effective to be a disinfect agent because their alcohol concentration is much lower. But I believe they may have somehow level of disinfection ability, but their fixation time should be much longer than expected. As I say previously, the alcohol concentration will be dropped lower than 70. So over 70, the virus would be disappear only 30 seconds. But if lower, takes 10 minutes to kill the virus. But if you are at very low concentration, I'm not sure the exposure time would be 1 hour or would be hours. And more than that, I'm not so sure the viral reduction would be 1 log, 2 log, or 3 log. It needs more experiments to prove these commercial fixative solutions disinfective abilities. So if you want to say you use a liquid-based cytology, is safe to kill the virus. So far, we don't have evidence to say that. Question 5. In my article, pleural effusion is one of the samples with intermediate risk. Why? Yes, honestly, I have explained it in minutes ago. Because the current truth is that no live infectious coronavirus have been isolated or cultured from pleural effusion, and no published articles show the detection of viral RNA in pleural effusions. And third, the pleural effusions are relatively seldom seen in COVID-19 patients. In reported articles, from 4% to 10%. So, but theoretically, the pleural and the pericardial effusion may have the necrotic or degenerated pneumocytes degenerated from the lung tissue and floating in the inflammatory exudates or effusions. So these effusions may have potential to have viral particle, but by current evidence, they are low risk. We just need to carefully treat them for possible contamination. So I put them into intermediate because we need to pay more attention toward them. The question 6. What will you refer to effusions previously treated with formalin, with alcohol, or not treated? If you treated with your effusions with formalin, yes, I think it is very safe to say they are inactivated. But if you pre-treated with alcohol solution, make sure the dilution proportion to make the alcohol concentration over 70%. Only when you make sure your alcohol concentration is over 70%, your sample are fixed as inactivated sample. And if you are without the pre-treatment solutions, you have better process it in a biosafety level 2 lab or isolate area, a dedicated area to treat these samples and effusions. I'll talk about this issue in page 5 of my article. Because not everyone's lab is a BSL2 lab. If your lab is not a BSL2 lab, remember to isolate a dedicated area, especially treat these high-risk samples. Because these dedicated areas, we can for sure to disinfect them before and after we treat the samples. Okay, thank you. I end my talk, and I think this COVID-19 outbreak will still go on because the Singapore and Japan have the second wave of the outbreak. This battle would be a long battle if we cannot successfully have the vaccination or effective drugs. But we have faith and belief in our friends, in our human beings, humanities, because we are all together in this global village. We help, we care each other, and I hope every our friends and my audience can visit Taiwan. Taiwan's flight is very cheap. Maybe take time, but the living cost and the tourist cost is very low in Taiwan, and it's very modern in Taipei City. You can see the Taipei 101 Tower, and even just 2 hours you can visit a very traditional local village in Jiufen. So welcome everyone to visit Taiwan after this outbreak, and see you next time. Bye.